Hi, and welcome everyone. Again, this is Richard Mall with the Long-Term Care Community Coalition. For those of you who are not familiar with us, we are a nonprofit, nonpartisan organization entirely dedicated to improving care and quality of life for elderly and adult disabled people in nursing homes, assisted living residences, and other long-term care communities. The primary focus of our work is policy research and analysis, and we use that to support our systems advocacy. But over the past, I would say 12, 13 years now, we've been doing more and more public education programs such as this. We have a number of resources for families, residents, and ombudsmen, and those who work with them on our website. Everything is free to use and share. And lastly, but certainly not least, we are home to 2 local long-term care ombudsman programs in our home state of New York. Our program today, I'm really excited and interested myself, so I think it'll be a great program. And again, thank you for joining us. The program is called How Fear of Retaliation Scares Residents into Silence. And again, the program will be available this afternoon as a recording, and the materials are available at nursinghomeforward1.org/webinar-retaliation. Guest speaker today is Professor Elan Caspi. He's a gerontologist and dementia behavior specialist. He started working in the aging field almost 30 years ago as a nurse aide in a nursing home where his grandfather lived. He's also worked as a social worker, as a consultant, especially particularly in dementia care, I believe, as an applied researcher, educator, author, and certainly as an advocate in long-term care homes. Elan was a board member of the Long-Term Care Community Coalition, and he stepped down from being a board member so he could do some of this work for us. I've seen a little bit of it, of his research. It's really important, striking, and moving, and I'm really looking forward to him sharing it with us today. And so without further ado, I am going to hand it over to Elan.
All right. I'm going to share my screen. I hope you can see the screen.
Yes, thanks.
Okay. I'm going to just minimize the windows on the side here. Okay. Well, welcome everyone. Thanks for joining us. Today we're going to talk about a phenomenon that is, I believe, under-recognized, understudied, and often inadequately addressed in long-term care homes. The title is How Fear of Retaliation Scare Residents into Silence. I don't have all the answers for how to address this phenomenon. There's a lot to learn. I hope that will be a follow-up project. But my hope is that this presentation will raise awareness and call to action to address it. I should mention that beyond an early survey many years ago at UConn, here at UConn Center on Aging, that showed that this phenomena is fairly common, I'm not aware of a single study, a published study that examined this phenomena. And I want to dedicate this project and webinar to residents who were harmed during these incidents. Your voice matters, and it informs our advocacy. So I want to just give a shout out to our upcoming report. It's a very comprehensive report. It's called They Make You Pay, How Fear of Retaliation Silences Residents in America's Nursing Homes. And we hope that will come out early this summer. I want to recognize the Long-Term Care Community Coalition for their generous support for this project. I want to thank Richard, Eric, and Haley for their support and advice and assistance throughout this process, including currently with the editing and formatting and the design of the report itself. I want to also thank for Mairead Painter, Connecticut State Long-Term Care Ombudsman, for the resources she shared with me and her insights. State surveyors, without whom this project would not be possible, that is, without the investigation reports that they complete. And the same goes for the Nursing Home Inspect of ProPublica. The data for this project was identified in their website. Now, before starting, I want to just mention that I honestly believe that most CNAs and nurses are caring. As one experienced and professional director staff whom I knew, she said, "We love working with the residents. It gives us joy that we can assist them in the evening of their lives. We truly care for the residents, and that honest care shows in the work we do." Here's a definition of fear: an unpleasant, often strong emotion caused by anticipation or awareness of danger. And one definition of fear of retaliation: a concern or feeling of vulnerability that one's action may cause retaliation by another. And retaliation defined as an actual or perceived negative reaction of a person as a result of another person's action or behavior. These are definitions from the initiative in Connecticut, Voices Speak Out Against Retaliation. And the National Ombudsman Reporting System provides the following definition for retaliation: acts of retaliation or revenge by staff in response to complaints to the care home, ombudsman program, or state survey agency. Or, as put by a nursing home resident years ago, fear of retaliation is not something you can look up in a dictionary. But if you live in a setting where you depend on others to care for you, you know exactly what it is. In this project, we will try to flesh out what this phenomena means and how it manifests. However, this phenomena is not new. The groundbreaking work of Irving Goffman in the mid-50s, 1950s, in Total Institutions, identified a series of acts of retaliation against people with mental illness living in those psychiatric hospitals. There are a few examples. Looping is basically causing a defensive response in a resident and then taking that very response as the target of the next attack on the individual. Hectoring is basically the bullying acts and the intimidating acts against residents. Goffman used the term mortification of the self, which is a series of acts that humiliate and degrade a person to discipline him or her. Another phrase that Irving Goffman used is the erasure of the civil self. And you can see other forms of retaliation on the slide from that study. We also know that staff retaliation against residents is not new. And in fact, we have records, reports on such acts over 50 years ago. A resident who did his bowel movements on the floor in a wastebasket received abuse from staff. Residents were biting, punching, or kicking aides, where in the aides' minds considered a punishable behavior. And a resident described as mentally confused and described as one that did not know any better was placed into a tub of hot water to punish him for cursing the orderly. According to one report, the severe injuries led to the death of that resident. This, as many of you are familiar with this important article, Old Folks and Dirty Work in Nursing Homes. And a government report over 20 years ago shared several examples. One of them, a resident in a nursing home in Ohio, sustained severe injuries. When he was asked who did it to him, he said, "He will beat me up again if I tell you." Later, he identified a male aide who confessed to abusing him. And we also have an occasional media reports. In Minnesota, an older woman had been in a nursing home to recover from pneumonia. She felt like a liquid is building up in her lungs, and she asked why her antibiotic medications were discontinued. According to her report, she didn't receive a response. So she asked again. In response, a nurse came and slammed the phone in her chest so hard that the resident said she almost passed out. She said that she had to lie for 20 minutes petrified without saying a word. She reported it to the state survey agency, but according to the report, it basically went nowhere. And eventually she got a note saying that The investigation was delayed until later that year. She wondered why she bothered even filing a complaint with the state survey agency and not call police immediately. She also said, quote, "This is why no one knows about these crimes. It's not because we don't have a voice. It's because people in power deliberately choose not to listen." Now, how common is fear of retaliation? Well, unfortunately, there's not a lot of studies to tell us, and we need more research in this area. But an early study at Yukon Center on Aging asked residents in different long-term care settings the following survey question: do you worry about retaliation if you were to report a complaint or concern? Nearly 1/4 of the nursing home residents reported that they worry retaliation if they were to report a complaint or concern. An additional 4% reported they do not want to complain, and 1% reported that they don't want to get people in trouble. Other more open-ended responses by residents were, yes, I heard a girl say that they know how to get even, so I try to keep my mouth shut. Another resident said, oh yes, always. That's why nobody makes a complaint. The administrator scares anyone, and he's very belittling and yells at people. Yes, there's a lot of retaliation, said another resident. Other findings from this study, several residents completed in-depth interviews on this phenomena, and based on these interviews, the researchers found that some instances of retaliation were egregious or highly visible, but others were more subtle in nature. Many forms of retaliation may not even be recognized by residents or staff. And this is important. Worry about potential retaliation was as fearsome for some residents as the experience of retaliation itself. We're going to return to that finding later. And those residents who felt conflicted about whether or not to report retaliation felt hopelessness and despair. We're going to return to that too. The study concluded that retaliation and fear of retaliation is a reality in any supportive housing situation. And as Cheryl Hannon, the Minnesota State Long-Term Care Ombudsman, said, this is a human rights issue. Vulnerable adults with complex medical issues are being retaliated against for the simple act of speaking up. Someone needs to take the lead here and stop the practice. And my colleague, Chris Sundberg, Executive Director of Elder Voice Advocates in Minnesota, said, we constantly hear about retaliation fears and actual harm to residents, families, and staff. This is a rapidly escalating problem that results in an inconceivable suffering, and it must be stopped. We also know that this phenomena represents a strong and persistent and chronic barrier for reporting poor care and mistreatment. According to the National Long-Term Care Ombudsman Resource Center, fear of retaliation is one of the most common reasons residents do not want to pursue a complaint and disclose their identity. Since residents live in a care home and rely on staff for their basic needs, their fear of retaliation cannot be overemphasized. Now, I was able to identify an early survey conducted by the Atlanta Long-Term Care Ombudsman Program. They found that 44% of residents who witnessed abuse of other residents did not report it. Half of these individuals didn't report it due to fear of retaliation. And Chris Sears, who is a reporter with the Star Tribune, who examined this issue of retaliation, wrote, the threat of retaliation not only terrifies residents, it discourages them and their families from taking steps that would protect their rights or enforce public regulations. So what were the project's goals? Well, I aimed to identify, I had 5 goals. Identify the circumstances surrounding and manifestations of 1, residents' fear of staff retaliation, residents' allegations of staff threat of retaliation, residents' perceptions of staff retaliation, actual or confirmed staff retaliation, and the 5th aspect is emotional consequences as a result of the 4 earlier aspects. The overarching goal of my project was to raise awareness to this phenomena and to call for policy, practice, and research action to address it. I should mention that in additional slides that will not be covered in this presentation, slides 95 and 96, there are areas for research identified that I hope researchers among you will consider studying. I also want to set expectations clear. The project did not aim to identify solutions. I believe that to do justice with this complex phenomena, we need to do a follow-up project to get the best minds in the country and to study this issue and then come up with a report with recommendations for addressing it. Now, we also know that there are serious barriers for conducting research on mistreatment, elder mistreatment, and retaliation in nursing homes. Here are a few examples, whether it's owners or administrators' reluctance to grant permission to conduct a study, such as due to concerns for liability, adverse publicity, or regulatory action. There are complex informed consent issues that need to be adequately and skillfully addressed, including the assessment of residents' cognitive abilities. Residents may decline to participate in research on this topic, such as due to fear of retaliation. And I should say that in some cases, certain staff members may not collaborate with researchers even after granting permission to conduct the study. And again, prospective studies can be very time sensitive and expensive. So one way to overcome these barriers, many of you are familiar with CMS Form 2567, which is a Statement of Deficiencies and Plan of Correction. It's a very rich data source that is underutilized. And I'm not going to go into details, but in general, it describes the failure of specific federal regulations, some background about the resident, and the findings, the evidence that was identified in support of issuance of the citation. However, this form is fraught with problems oftentimes. Take it from David Wright, the Director of Quality, Safety, and Oversight Group at CMS. It said several years ago, "It feels like a treasure hunt. That form has been around since dirt. It is an old and hard to read form. Who is going to read through it in a nursing home? We need to better compare information. People don't need to labor through it. There are ways to do it more efficiently and transparently. The more transparent we'll be, the more it will inform and guide our work." I couldn't agree more. However, CMS does not, to my knowledge, does not centrally track this phenomena in over 15,000 nursing homes nationwide. And yes, sometimes care advocates and researchers can't wait for data sets to be created and become readily accessible. More accurately, residents can't wait. The source of data was Nursing Home Inspect of ProPublica, which draws on investigation reports and surveys from CMS Care Compare website. With a search for the word retaliation, with a short keyword retal, I was able to identify 835 standard surveys and investigation reports, that same form I mentioned earlier. And my goal was to identify 100 of those surveys and investigation reports. And that comprised the final data set. Those surveys and investigations were completed. You see the dates on the slide between 2017 and 2022. I should mention that the majority of them were completed during the pandemic in 100 nursing homes located in 30 states. These are some of the surveys and investigations that were excluded, those over 700 reports. These address family fear of staff retaliation or staff fear of other employees' retaliation. Of course, these are as important phenomena, but they deserve full attention in other projects. And resident-to-resident retaliation also was excluded, among other reasons. And for each investigation report or standard survey, I created a template to summarize the human story, for which the first element is the title, an attempt to capture the essence, the nature of the incident, or a direct quote by a resident or staff. I included the deficient practice statement as written by the surveyor. There was a brief background about the resident impacted when available. And the biggest part of that one-page summary is of relevant evidence relevant to this phenomena. And then there was background about the nursing home, the name, the date the investigation was completed, the type of deficiency issued, severity level determined, the overall quality star rating, and staffing rating. However, important caveats are the type of deficiency issued was often not directly relevant to the 4 aspects of retaliation examined in this project, and the severity level were often not directly relevant to the suffering and harm reported by residents. So therefore, caution is therefore needed when interpreting the findings related to these data elements. So going into the findings, and really the core of the project is residents' lived experience in their own words. Here I'm going to share a series of quotes from residents. I prefer to stay quiet to prevent retaliation. I'm afraid they are going to retaliate against me. They make you pay. No matter what you say, they will make you pay for it. Can't say their names, don't want to pay the price. Another resident said, they will come at me. It backfires on you. Residents get chewed at when a concern is voiced. I feel like I'm retaliated against when I complain. You did not want to be on the wrong side when it went off. I was worried she would try to kill me by over-medicating me. Another resident, and I'm sorry, here was a medication aide who witnessed a verbally abusive retaliation by a CNA against a resident. The medication aide said it was like she was out for blood. A staff member who witnessed a really cruel retaliatory physical abuse by a coworker said that she or he never saw such evil. A blind resident said that he or she were put through hell for reporting incorrect dosage of blood pressure medication. I was told what she has, if I told you what she has done to me, she would just make my life worse, said another resident. Another resident said, I didn't like to complain because it would come back to haunt me. The staff would retaliate. A resident said, they would just gang up on you like a pack of wolves. Oh, it will come back on me. It will be abusive. It will be bad. She would figure out a way where I couldn't defend myself. I felt threatened for my life, said another resident. A resident was terrified of being evicted and felt powerless and helpless. Another resident said, this is my home. I don't want to live here, and I fear retaliation. When speaking with state surveyors, one resident said, I'm literally afraid of her. She intimidates. Are you sure nothing is going to happen to me? Another resident in another nursing home said, what am I supposed to do when you leave? I still must live here. I don't want to talk anymore. When speaking with an ombudsman, Mered Painter shared with me this conversation. How come you won't let us address these things, these care-related problems that came up? The resident said, you get to go home. I have to stay here all weekend. And once you go home, everything changes. During another interview with a surveyor, a resident stated that an aide pulled a mechanical lift harness roughly behind her, but the resident did not want to report it due to fear of retaliation. The family member said that the resident told her to stay quiet about it. And the resident said, you have to be careful about what you say around here. It will come back to you. When asked if the resident was ever hurt by staff, the resident would not answer, turned her head looking towards the door and said, they are out there. They are listening to everything. When her family was starting to talk shortly later, the resident said, you don't understand. You have to keep your mouth shut. Moving in more depth into the 5 aspects examined in this project. The first one is fear of retaliation. Many residents were convinced that the reporting on right violations, poor care, and mistreatment will result in staff retaliation. Many were fearful, some were terrified for their safety if they were to speak up about care concerns and mistreatment. Many chose to remain anonymous when reporting concern and mistreatment to employees and state surveyors. Some chose not to identify the alleged perpetrators for fear of retaliation. Others chose not to speak at all about violations of their rights, care, and mistreatment. In this incident, a resident said, I felt threatened for my life. And a nurse who spoke with the resident said that the resident kept saying she felt threatened. Her life was in danger due to physical abuse she experienced the night before. The resident did not report it due to fear of retaliation from the aide. To protect herself from what might happen during the night, she kept her reacher by her side in bed out of fear of the abusive aide. One resident stated that he was slapped on his head by a CNA, but he didn't want to say anything about it. The resident added that the CNA was bigger than him. Another resident was fearful due to an incident in which a CNA allegedly wrung a towel soaked with hot water on her private parts. Some residents were so afraid of retaliation, they didn't want to report mistreatment. Therefore, they remained mistreated and neglected to avoid retaliation by a particular employee. There were several cases where residents stayed in soiled adult depends for hours, sometimes all the way to the next shift, just to avoid a particular abusive or retaliatory staff member. In the words of Ronnie, a nursing home resident many years ago, fear is very powerful. It can paralyze some people to the point where they'll let just about anything happen without reporting it. Some residents gave up on trying to voice grievances after their grievances were continuously ignored or resulted in retaliation. One resident said, filing grievances was pointless, as staff back each other up when we asked about a situation and then become total terrors. An anonymous resident said that an agency staff were too rough, mean, and yelled at the resident and other residents. The residents began to cry and said that they felt like they just had to let things roll under the rug because it was just part of being in a nursing home. The resident felt it did not do any good to tell anyone because they kept bringing more and more agency staff, and if the residents did tell someone, the staff would just treat you worse. The resident said that he or she knew that other residents felt the same way, and if the resident said anything about it, it just comes back on them. One of the concepts that emerged in this project is learned helplessness, which is defined as repeated exposure to uncontrollable stressors, resulting in people failing to use any control options that may later become available. Essentially, people are learned that they lack control over environmental events, which in turn undermines the motivation to make changes or attempt to alter their situation. And in many cases, the mistreatment was perpetuated. Fear of retaliation led to lack of reporting or delayed reporting of poor care and mistreatment. Right violations, poor care, and mistreatment often remain uninvestigated. In several cases, alleged perpetrators were allowed to have continued access to fearful residents. Another pattern that came up in this project is extensive evidence, overwhelming evidence of the power imbalance in the specific context of resident fear of staff retaliation. Many residents were physically dependent on extensive staff assistance with ADLs and medical care. And indeed, the early study by Professor Julie Robinson from Yukon Center on Aging found that residents with worse health were more likely to express fear of retaliation. And a recent review of dozens of studies recognized the imbalance of power between residents not being able to draw attention to their experience of abuse and staff probably not reporting abuse to protect themselves or their colleagues. The second aspect examined in this project, these are the findings. Residents reported, that is, residents' allegations of staff threats of retaliation. Residents reported experiencing various forms of staff threat of retaliation, whether it was threats to delay or not provide services and care, threats to neglect and abuse residents, threats of physical violence, threats of retaliation if a resident will report on being sexually abused, and threats to discharge residents. In one case, a resident said that the staff threatened the resident and his or her roommate if they complained to the survey team and said that once the surveyors were gone, things would go back to the way they were. In one case, a family member asked why their relative had not been showered, had not had their teeth brushed, and had not had their soiled adult depends changed. In response, the CNA said, "You better not call state, or it will be worse for the residents." Excuse me. Now, another threat of discharge. So imagine yourself sitting in your bedroom in a nursing home on Friday at around 4 p.m. Without advance notice, male residents were told, "We're moving you to an all-man secure care unit," against their will. If you refuse to move, well, the director of nursing said that's where the 5-day discharge letter comes in. One of the residents who was forced to do it said, they came on one day and said, "We're moving you," without any warning. I said, "No." And the administrator said he would kick me out, so I moved. And again, there's media reports examining the issue of what happens to residents when they speak up and they suffer the risk or actual eviction. One older woman lived with her husband in a senior home in Minnesota. She suffered a pulmonary condition that was so severe, her doctor ordered her to avoid smoking. Now, the care home had rules that prohibited smoking, And when she complained about smoking, the administrator, according to her report, threatened to evict the couple for misbehaving and stirring up trouble. She said, "We were petrified. We were being labeled as troublemakers and had nowhere else to go." The couple could no longer live with the threat of eviction and the breathing difficulties from the regular exposure to smoke. They eventually moved to a different assisted living. And the woman asked, "How would you like to be forced out of the home where you've lived for 12 years?" The third aspect examined in this project, these are the findings. Residents perceive staff retaliation, whether it's delays in care, neglect, psychological abuse, whether it's being yelled at, cursed at, mocked, and receiving the silent treatment, being confronted aggressively when residents reported care concerns and complaints, whether it's physical abuse or forcing residents to do things against their will, harassment through one-on-one, 24/7 continuous supervision, real violation of privacy there, and other rights violations, such as preventing residents from socializing with other residents. In this case, an anonymous resident told the nurse that something seemed off with their medications. The nurse became mean to the resident and one day said, and one day the nurse came behind the resident, leaned over to give them a hug, and then whispered in their ear, "She could beat the shit out of me and no one would know how she did it." The resident said, "I was terrified." The resident was afraid to say anything, but finally had to say something when she noticed multiple medication discrepancies. One resident alleged that an agency staff took a towel with feces on it and placed it on the nose of the resident. The reason? The resident did not want the aide to use paper towels to clean her. She wanted her to use a towel. A resident said that a while back I had to poop on myself because there was a wash basin with urine in it sitting in my toilet. I had to urgently poop, but first I had to urgently move the basin filled with urine, and it took too long, and I had ended up pooping on myself. After clearing himself up, he took the wash basin and placed it on the desk at the nurse's station, and when he was asked about it, he told them why he did it. Shortly after, he smelled urine in his bedroom for 2 days. He found the same basin with urine in it inside his bedside drawer. He asked the surveyor, "Can you believe that?" The fourth aspect examined in this project is actual or confirmed staff retaliation. The first domain here was verbal or psychological abuse, harassing, intimidating residents, yelling at them, and cursing at them. In the physical abuse domain, while in bed, a resident was forcefully pulled by the neck forward towards her feet, causing pain and a C2 plate displacement in the spinal cord, requiring hospitalization. What was the reason there? Well, the resident spilled her medications in bed or around it and couldn't find it, and the staff member lost it. Another case, a very cruel retaliatory physical abuse, where during rejection of personal care, a staff member grabbed the pinky finger of the resident, bended it backwards towards his wrist until the resident screamed. There was shower scolding in another incident, and then several reflexive slapping and punching and hitting residents during rejection of care by residents with cognitive impairment. Moving on to the fifth aspect examined in this project identified a wide range of negative emotional and disturbing consequences were identified here. While the severity varied, many residents suffered tremendously and were emotionally devastated, whether it was increased frustration, anxiety, fear, anger, sadness, depression, and helplessness were reported by many residents. Residents felt disregarded, ignored, belittled, infantilized, and humiliated. Some residents felt isolated and trapped. One resident said, "I feel like a prisoner in jail." One resident expressed concern about abrupt repositioning by an aide at night. He worried all day about what will happen at night. He said, "When I get up in the morning, my biggest concern is what will happen in 12 hours when I go to bed at night." He declined to identify the aide due to fear of retaliation. Residents were really scared. Residents worried about their security and safety. After staff verbal abuse, one resident said, "I got scared the whole day." One resident said was terrified after staff threats of physical abuse and violence. Another resident had terror in their face when recounting a registered nurse's verbal abuse and physically injurious abuse. The resident said they almost broke me in half. Some really feared for their lives. One resident said she or he was scared to death. Many residents expressed helplessness due to inability to defend themselves from abuse and retaliation. Residents were worried about the safety of other residents, such as roommates, who could not speak up for themselves, perhaps in advanced stages of dementia. They were also worried about employees who tried to protect them. In this case, a resident A had moderate cognitive impairment and experienced a bowel movement accident. Resident B stated that the CNA reacted by screaming at resident A for at least 10 minutes. And I'm going to try to fill in the blanks here. God damn it, man. You're too old for this shit. I can't believe you shit yourself again. You're a fucking baby, man. Resident A, the victim, was so angry and visibly shaking after the verbal abuse. Some residents, again, were worried about other residents. A resident who was cognitively intact stated that he was left soiled in urine and bowel movement for over 30 minutes. Out of frustration of reporting issues or complaining, he said, I prefer to stay quiet to prevent retaliation. My complaining is mostly for those who cannot advocate for themselves. Because while being cognitive and verbal, I get this kind of treatment. It saddens me even thinking about the kind of treatment those who cannot speak and are not cognitive are getting. Another pattern was residents felt dehumanized. Specifically, residents, in their own words, felt treated as less than a person, as the lowest form of life. One resident said that staff acted like we were non-people. They don't even acknowledge that we are human. I am not a piece of meat. I am not a pile of dirt. I have rights. Dozens of direct resident quotes indicated the dignity of many residents was at risk or violated. Dignity is defined as the quality or state of being worthy, honored, or esteemed. A gentle reminder, residents have a federal right for a dignified existence and to be treated with respect and dignity. Now, while this project, the fifth aspect, looked at emotional, psychological consequences of this phenomena, while examining the data, physical pain also was experienced by residents. Some of these incidents we reviewed earlier, when you're being forced in bed and suffering a C2 dislocation in your spinal cord, and the resident said, I felt I was broken in half, you can imagine the level of pain that this individual experienced. Or when having, again, your pinky finger bent backwards until the resident screamed, being scolded during a shower. One resident alleged that the staff banged his head against the side rail really hard, and that the staff then took a urinal and smashed it against his private parts over and over really hard. In another confirmed case, an aide pressed a metal tray against the resident's face, causing swelling and redness beneath the eye. And residents were being punched in the face. In one case, it caused bloody nose and mouth. That was in retaliation for rejection of personal care. And one resident with moderate impaired cognition was masturbating in a little room connected to the nursing area. A registered nurse went up to him, grabbed his penis, and screamed, "If you don't stop that, I'm going to rip that thing off." Staff witnessed it, said the resident screamed because their RN grabbed it so hard. So I shared the emotional consequences with Mairead Painter, who is Connecticut State Long-Term Care Ombudsman. I asked her, as a state ombudsman, what is your reaction to that in general? She said, it is sickening, and it just shows we need to do a lot more education and outreach. Other findings in this project, and there's much more in the report that will come out early this summer, the overall quality star rating on a 1 to 5 scale, if you will, for 98 nursing homes for which data was available, the average was 2.8, which is somewhat below state average. And you can see the distribution on the slide here. Essentially, what it tells us is that this is preliminary evidence suggesting that the phenomenon may exist in nursing homes across all overall quality star ratings. Of course, a more systematic study is needed, a larger scale study is needed to examine the nuances for each of those 4 aspects examined in this project. And for staffing ratings, the average was 3, which is at state average. You see the distribution on the slide here. And again, preliminary evidence suggests that the phenomena may exist in nursing homes across all staffing ratings. That said, I have strong reasons to believe that low-performing nursing homes with dangerously low staffing levels probably have higher level of staff retaliation, but that again, it's an empirical question for future research. In conclusion, this phenomena represents a source of resident suffering and harm in U.S. nursing homes, and it remains understudied and inadequately addressed. The voice of many residents remains silenced, literally. It is time to break the silence and dangerous normalization of this phenomena. On the practical implications, just one general direction: we need to develop, build on, and deliver and evaluate educational and prevention programs. These programs are needed for all care employees, direct and indirect staff, that is housekeeping, kitchen staff, front desk, maintenance, anyone who comes in direct regular contact with residents. It also needed for grievance officers in each nursing home, managers, and owners. Of course, education needs for residents, family members, and friends. Long-term care ombudsman programs may need strengthened education, state survey agencies, law enforcement, and other state agencies. I want to just caution by saying that just telling residents to speak up without ensuring first that they have strong protections in place could do disservice to them and potentially even harm them. So we need to be mindful of that. In terms of policy implications, CMS needs to educate residents and families about their rights in this specific context. They need to strengthen oversight and protection, deterrence and enforcements related to this phenomenon. They need to centrally track all violations related to this phenomenon. And they urgently need to launch a data-driven national campaign to address it. Another policy implication: Connecticut passed over a decade ago a law requiring annual in-service staff training on residents' fear of retaliation in nursing homes. And there's the link to the law on the slide. I'm not aware of other states that have similar laws beyond specific clauses under resident rights trainings. So you need a comprehensive training to address this complicated issue. My hope with other states will consider passing similar laws as a result of this project. But we also have to ensure that new laws are applicable also to assisted living residences. Here's an example of retaliation in assisted living in Minnesota. One resident was paralyzed in all 4 limbs. The residents became upset about staff handling of mechanical leave during transfer. The resident said he's going to report it to management. Staff member overheard it and responded by physically threatening, harassing, and humiliating the resident. MDH investigations substantiated staff emotional abuse of the resident. Now, when crafting new legislation on this phenomena, I would urge you to that you will expect and prepare for a pushback from the long-term care industry. This is a statement, kind of outrageous statement by a CEO of a company. He said, the premise of this bill, the Connecticut bill, is that was 5 weeks prior to the bill passage. The premise of this bill is that somehow those of us who have dedicated our lives to caring for frail elderly will now retaliate against them. It is an outrageous premise, frankly. Well, I think that this project provides the empirical evidence to support the need for such training across the country. And some administrators are indeed out of touch with the ground level. They operate like in 30,000 feet above ground. I've seen it myself. One administrator in my project said, "I'm surprised that this is the culture. I'm not aware that residents are afraid of voicing concerns." I believe that the ultimate goals of this project, or our project collectively, is to restore residents' trust and confidence that they and their families would never fear staff or managers' retaliation when speaking up about care concerns and mistreatment in long-term care homes, long-term care settings, which is their home. We need to ensure that their voice is heard and respected, and we need to ensure that they remain safe. And I want to just share with you a poem that you can read later on that I wrote about various scenarios that could occur when the voice of older adults is disregarded. And I want to close with a few reminders. The nursing home complaint process is the frontline system for addressing consumer concerns, tell us the U.S. Office of Inspector General. This is a critical safeguard to protect vulnerable residents. I'm afraid that this phenomena weakens those safeguards. The second reminder is that federal nursing home regulations state that the resident has a right to be free of discrimination, of reprisal from the nursing home in exercising their rights, and they have the right to be supported by the nursing home in exercising their rights. This is a rights policy from a nursing home in Texas. You, the resident, do not give up any rights when you enter a nursing home. The nursing home must encourage and assist you to fully exercise your rights. Any violation of these rights is against the law. It is against the law for any nursing home employee to threaten, coerce, intimidate, or retaliate against you for exercising your rights. A third reminder is CMS deficiency citation F585 related to grievances. The resident, has a right to voice grievances to the nursing home or other agency without discrimination or reprisal, and without fear of discrimination or reprisal. And CMS makes it very clear that retaliation by staff is abuse, regardless of whether harm was intended, and it must be cited. And I would add, there should be zero tolerance for retaliation. And in closing, a nursing home resident said here in Connecticut many years ago, if you are afraid of anything, I don't care how little or big it is, you should be able to tell somebody, whether it be for yourself or someone else. And Carol Rosenwald, who was a nursing home resident and an activist, said, none of this will happen overnight. You must hold on to your ideas and always have the courage to speak your mind. Carol envisioned a time when the voices of nursing home residents would be heard beyond the walls of their facilities. I just want to point out in the last minute that I have that there's few resources, very innovative resources here in Connecticut, Ombudsman, long-term care ombudsman, that Mairead Painter shared with me, whether it's the Voices Speak Out Against Retaliation website. On it, there's the training video that is very powerful, and you didn't watch it, in the residents' words, a training guide, and information about the Connecticut Voices Forum. There's also fact sheets here from the Consumer Voice and the Long-Term Care Community Coalition about residents' rights and rights related to grievances. And I want to just cite and give credit to the Yukon early study that examined this phenomenon. I just want to mention that there are also areas for research. I'm not going to go through them, but those researchers among you can go through it later. Really a need to study this phenomenon, different aspects of it. And there's also other findings in the last slides. So this is my presentation today. Thank you for joining us today, and we're going to open to some question and answers. Thank you.
Elan, thanks so much. Really appreciate what just a tremendous, meaningful presentation. Let me see if I could find here we go. Okay, that shows up. So we're going to open up to Q&A, but first, a couple of housekeeping items. Please join us on next Thursday, April 27th at noon Eastern for our next Family Empowerment Half Hour. The topic will be negative ageism as a family advocate. So a lot of comments today in the chat about family advocacy and how to make that more meaningful. And then please join us for our next webinar, which will be held on Tuesday, May 16th, as always at 1 p.m. Eastern. The topic is nursing home quality improvement and expectations for responsiveness to complaints and citations for nursing homes. So trying to get again at how can we leverage some of these issues. Again, something that I saw a lot in today's chat. So please join us next for our next program in May. Head to nursinghomes411.org for materials from today's webinar, including Elan's slides. The recording will be up by the end of the week. To watch previous episodes of LTCCC's Family Empower Half Hour, like us on Facebook, facebook.com/LTCCC. Actually, that's for the forthcoming Family Empowerment Half Hour, is not the best one. Sorry about that. To register for the May webinar, please visit bit.ly/NH411-May2023. And then for materials on, for our forthcoming report that Elan is working on this issue and on his study, please go to nursinghomes411.org/retaliation. We expect that report to be out in June, by the beginning of the summer. And we'll stop sharing, open it up for Q&A. And the Q&A, the first question I have is from Christine Sundberg, And she asked, will you be expanding your research to management retaliation towards staff that advocate for addressing issues with the residents' care? And she said, Elder Voice Advocates in Minnesota is getting many calls from caring staff who are either fired for advocating for residents or quit because of the intolerable environment.
Thank you, Chris, for this important question. I do sure hope so. It will have to do with funding. But while I was going through those 100 and so investigation reports, I came across many investigations that addressed exactly this issue of staff fear of co-workers, supervisors, and managers' retaliation. So again, it's as important. I would add to that, I hope to do a project on family fear of retaliation as well. We know it's a huge issue. So yes, thank you for your question. That's my hope.
Thanks, Elon. Anonymous attendee asked, how do we prove without further retaliation, intimidation, and retribution? Also, I found that if I ask for help, I am told I should try to, quote, go along to get along, unquote.
Well, I will need a little elaboration here. So how would you understand the question? Because I couldn't really understand it fully. I'm sorry.
I think it's, how do we prove that something happened? And so, yeah, you're right.
Okay.
It's unclear. It's a good question, but it's a little bit unclear exactly what the person's asking.
Okay. Well, first of all, I would say that documentation is critically important. And when you're a resident or family, documenting things very, very thoroughly is very, very important, because once there is an investigation, whether it's the ombudsman coming in, whether it's the state coming in, whether it's police coming in, then, or when the family comes in, then you can have enough evidence to support it, and that will comprise whether it's in the clinical records, whether it's the personal records that the resident or family keeps, whether it's interviews with staff members, whether it's interviews with other residents, very important, and observations as well in the care home. And different states have different I should say that CMS has federal guidance protocol for investigating mistreatment complaints, but the implementation varies across states. But these are some of the sources of evidence that together, when gathered in time, unfortunately, many times state investigations occur months after the allegation is made, then it's really hard to collect adequate and sufficient evidence. Thinking about staff turnover, residents may decline in condition or move to another care setting or die. So these are some of the things to consider. But again, adequate and timely documentation and bringing the relevant organizations into the picture as early as possible is critically important. I want to just mention an innovative initiative here in Connecticut that Mairead Painter shared with me. She says that assistive technology is your friend. Now in Connecticut, residents during the pandemic receive iPads, all the recreation departments, and residents there's a bill, I hope I do justice with this, but there's a bill that passed here in Connecticut that allow residents to use any technology of their choosing. And now you can see, a resident can audio record, video record, abuse, they can record other forms of mistreatment and retaliation and send it directly to the ombudsman or state survey agency. So there's some innovative things going on around the country that we can all learn from.
Thanks, Elon. And I would just add two things. One is that this is the kind of problem people are afraid, but they want to report it and do something about it in as effective a way as possible. This is a way that a resident council can come in and a family council can come in, because they can make a general complaint without it coming from a certain individual. So that's one tool. And then the other tool I would say is on our Family and Ombudsman Resource Center, we have forms, as Elon was saying, documentation and tracking. We have easy to use forms so people can track and write down issues that they have, when they had it, who they spoke to, if anyone, et cetera. And that's a good way for keeping track of problems that you have, whether it be, obviously problems about abuse or retaliation or any problem.
Richard, I just want to say real quick that I know that ombudsman needs permission from the resident in order to move forward with a care concern, a complaint. That's a very important issue, and and that the ombudsman operates under the resident directed. It's a resident directed advocacy, so that's an important issue there, because residents may choose not to report it to the ombudsman.
Right. Although ombudsman can make complaints on their own in certain circumstances. Next question is from Karen Klink. How do residents and resident reps get taken seriously? And let me just say that I reviewed many of these questions, and they're big questions and not always perfect answers. I mean, this is really, as Elon said at the beginning, no one has really done this kind of research before, certainly not specifically looking at the complaints as he did, and coming up with such a robust body of evidence for what has been substantiated as fear of retaliation. So we have really a lot of really good questions, but again, some of these questions are maybe not fully answerable. But I'm interested in your insights.
I'll give it a shot. So we know that there's a certain power dynamic in mistreatment situation, elder mistreatment situation, and retaliation is not different. And so there's multiple ways in which resident, this is one kind of general direction. One is to seek peer-to-peer support. You know, when you have multiple residents, or even two as much could be stronger than one, multiple residents going forward and documenting things, their voice could be stronger. And then you have resident councils where the space is created in a private way, and really to truly come forward with issues. And when this is being taken seriously, that's another way. And then there's a family council. And then there's to work with the ombudsman on learning about your rights and what you can do. What are the options for doing about it? But again, it's about how to break that power dynamic, this gross asymmetry of power that we discussed, in order for your voice to be heard. But I'm not devaluating the enormous challenge, as we've seen in this webinar, for residents who could be fearing for their safety and their life if they do. So these are just some of the ways. There's also to make sure that the grievance officer in nursing homes, there's a requirement there so that they are involved and they are held accountable, and the administrators and director of nursing and the owners are held accountable and are truly engaged in these issues in a meaningful way, truly listening to the residents and their concerns.
Thanks. So we're going to talk a little bit about the grievance officer on our program in May. So Eileen Henshaw asked, how is retaliation against family members treated? Is it studied separately or as part of resident retaliation?
Well, of course, it could co-occur, right? But we wanted in this project to have robust empirical evidence that is coherent on this phenomena. And we want to do a follow-up project on family fear of retaliation, and as I mentioned, staff fear of retaliation. But we know from many reports over the years that staff are very afraid to report, and sometimes there's different views. It could be that a family wants to intervene, but the resident is terrified. So how do you navigate that? There's those nuances. It's not necessarily that they're in the same. They're seeing it in a unified way. So there's a lot for us to understand. I'm not aware of a single study, and please do tell me if you're aware of other resources on fear retaliation in other states. If you're aware of other projects or surveys on staff fear retaliation or family fear retaliation, please do share them with us, because we're trying to compile them for this project.
Great. And you could email feedback@ltccc.org, and we'll get that to Elon if you have any of those resources. I hope I'm pronouncing your name correctly, and I apologize if I'm not. Fuad Abujarad asked, fear of retaliation is strong and persistent. How can we motivate self-reporting of abuse and retaliation? Just saying.
Well, I think that you need to make the laws needs to be strong. You need to have strong regulations. You need to have strong setting expectations. There should be a very clear policies of zero tolerance. Every resident and family and friends should know the rights. There should be strong deterrence, very, very clear deterrence for staff and managers of doing it. There should be strong enforcement, and it's a community effort. And so it is still going to be a challenge in many cases. But that's why you have the long-term care ombudsman. That's why you have care advocacy organization and state survey agencies that can, particularly the ombudsman, can help you navigate those challenges. But they are persisting challenges and complex challenges that we need to better understand in the future.
Thanks, Elon. And we're a little bit over. I'm gonna do one or two more questions. We have a number of questions that asked about hidden cameras. So here's Amina Ship. Again, I hope I'm pronouncing your name correctly. Are CCTV cameras used with residents or power of attorney consent in nursing homes in the United States? This individual's in Australia, and footage has proven to be vital as evidence in abuse cases, which we actually saw in the chat as well. Some people mentioned, but the use of cameras, please.
Right. So, the National Consumer Voice for Quality Long-Term Care came out with a fact sheet about electronic surveillance and cameras that could provide some important directions to consider. And yes, there are issues of privacy, there are issues of consent, there are issues of roommates' privacy, and we need to be mindful of them, and we need to account for them, and we need to work with them. However, there are all too many cases where a family would report a concern, it would be disregarded, they report again, they try to work with the staff and the managers, and nothing happens. And they're pushed to the corner, and then they're left with the last resort to put a camera. And then that footage could oftentimes be overwhelming evidence of what actually happened, not what he said or she said, or dismissing residents with dementia. They don't know what they're talking about, they don't remember, etc. So it has a place, but it has to be done in a thoughtful, responsible, and respectful way that protects residents' preferences and privacy rights.
Thanks. And I would just quickly add, and we'll do one more question after this, that our position as an organization has always been essentially twofold. One, as Elon is saying, that if a camera is to be put in a resident's room, if possible, that resident should be expected that the resident gives permission for it. And if the resident doesn't have capacity to do that, that it be done in a way that is as much as possible respects that individual's dignity and privacy. And then in terms of the legality, again, is our position that it's the resident's home, and therefore the resident is entitled to have a camera in their home. But as Elon noted, the other individuals in the facility have a right to privacy too. In particular, if there's a roommate or a roommate's visitors, they have a right to privacy. However, it's important to note that working staff do not have a right to privacy or an expectation of privacy in the facilities. So you would want to make sure that you were protecting, ensuring that any visitor or any other residents in the facility are not being recorded. But again, the staff don't have the right to privacy. I
just want to mention that I'm aware of families that were retaliated against, and the resident was retaliated against after families were expressing concerns and complaints about mistreatment, and even identified mistreatment caught on camera that they placed, and then the resident experienced retaliation by staff. In fact, one family, it meant that the residents suffered neglect, a retaliatory neglect, after the family came out with camera footage to demonstrate mistreatment that was brought to the attention of management. So that's that too.
Sorry, thank you, Elon. Just one last question, which I think is kind of interesting. I'm sorry that we're not able to get to everyone's question, but Rashmi Shah asked you, Elon, if you've considered researching retaliation in prison, you may find a lot of similarity. I thought that was.
Well, I think that's very insightful. I think it goes back to how we started with the groundbreaking sociological work of Irving Goffman in the mid-50s, where he identified parallel lines, if you will, between total institutions, whether it was army bases, psychiatric hospitals, and other places where total institution is defined as a place of residence and work where a large number of like-situated individuals for an appreciable period of time, together lead an enclosed, formally administered round of life, cut off from the wider society. That's how he defined it. So army bases are in there, and prisons are in there as well. So what are the parallels? What can we learn from other total institutions? This is a very interesting question.
Great, thank you. Thank you so much, Elan, for just a tremendous work and thoughtful and moving. We really, and important, I think we really appreciate it. Look forward to the report coming out. Again, everyone, please check back with us in early June or sign up with us to be alerted when that report and other reports come out. Thank you, everyone, for joining us, and we hope to see you next month. Bye now.